From the Sammy Wiley Institute headquarters in Alexandria, Virginia, this is On Human Flourishing. I'm Dr. Wayne Jonas. My guest today is Dr. Adi Haramati, professor of biochemistry, molecular and cellular biology and medicine at Georgetown University. In this role, Dr. Haramati is the co-director of the complementary and alternative medicine program at Georgetown, one of the first programs of its kind at the U.S. Medical School. Most recently, Dr. Haramati is the founding director of the Center for Innovation and Leadership in Education. This center focuses on enhancing medical education skills for teachers in healthcare. Adi, thank you for coming in, and it's a great pleasure to have you here.
Well, thank you for inviting me.
So let's start off with integrative medicine as sort of the first area. Can you tell our listeners what the heck it is? I mean, integrated, integrative, complementary, alternative, healing components. There's lots of terms that are floating around here. What is meant by that?
So you're right, the terms are confusing. What we mean by integrative medicine is an approach to medicine that provides the combination of the best in conventional medicine with the best in what we call, quote, alternative medicine. Alternative being things that are outside the mainstream. That's a definition that's changing rapidly from each year. What was alternative 20 years ago, in some cases, is already mainstream. But in a general sense, we could say that things are alternative. For example, mind-body practices like meditation and mindfulness training, and may even spirituality. Biologically based therapies would be things that we take by mouth, like various diets, herbs, supplements of that nature. Body-based therapies would be those therapies that involve manipulation, like osteopathic and massage and chiropractic care. There's a fourth category called energy medicine, which would be things that we don't quite understand, but seem to have interesting effects on body function, like Reiki, or even acupuncture might fit into that category of an energy type of therapy that we can't directly measure with current tools and instruments. And a fifth category of alternative would be systems. For example, traditional Chinese medicine that combines diets with spirituality and with movement, and Ayurvedic medicine from India that would combine spirituality with various dietary approaches, and also yoga. So systems with specific therapies, integrative medicine would take the best of all and combine them. And as just one example of how integrative medicine might be practiced, an individual, say, with osteoarthritis of the knee, a very troubling, painful condition. Prior to the use of integrative medicine, the alternatives were some very powerful drugs, pharmaceutical agents to reduce inflammation that eventually were taken off the market because they were so dangerous, or surgery, another invasive procedure. But an integrative approach would be to combine that with, to use as an alternative, acupuncture, and to use massage as two approaches that have been shown to be effective, that are a lot less invasive, and have been shown to actually have similar outcomes compared to the standard treatments.
Mm-hmm. Fascinating. So these are, in some cases, ancient practices that have not been part of Western biomedicine, and in some cases, more modern practices. When I went to medical school, I learned practically nothing about nutrition. Is that considered an alternative practice still, or is it now more mainstream?
Strangely enough, if you think about nutrition, we've known for hundreds of years about nutrition, and vitamins were discovered 100 years ago. But as you say, the amount of time devoted to nutrition per se as a therapy is very little, and only recently come to a fore. And when I say recently, I'd say in the last 10 years that the NIH actually had a grant mechanism for nutrition programs to be developed in medical schools, and for schools to begin to realize that food is medicine. So in some cases, an integrative approach using nutrition, for example, to deal with pain, you might wonder, how does that work? Well, it turns out that with taking the right kind of diet and using the right kind of foods that reduce inflammation, So we know that some foods are pro-inflammatory, that create inflammatory conditions in our heart and our joints. And to switch to a diet that is less inflammatory would actually relieve pain. And so there's a sound scientific basis for thinking about a nutritional approach as a therapeutic one in some cases.
So the integration is not just the integration of treatments that haven't been part of biomedicine, but in some ways the utilization of things that normally would be considered lifestyle in prevention and therapy. That's part of the integration.
That's exactly right. I mean, you know, many of us, if we just sat down and said, okay, what do I need to do in my life right now? And most people would say, I need to move more, I need to lose some weight, I need to be more active, I need to reduce my stress. A lot of this is not new thinking. What it is trying to figure out, how do I combine that without adding to my to-do list of blocking out 2 hours for the gym and an hour and a half to prepare a meal, and an hour to close the door and not be bothered with whatever I'm bothered with. Those are the practical realities of living in the 21st century, when we have smartphones that beep us every 15 seconds with another text. So we're challenged. We're challenged with ways to try and balance our life and at the same time optimize our health. And that's what we're trying to create with this integrative medicine program.
Right. Well, I know you were one of the first to receive an NIH grant to begin to train individuals, physicians, healthcare practitioners, others in how you do this type of integration. And I'm just wondering, could you tell us a little bit about that program? Why did you start it, and why did you design it the way you did?
It's a wonderful question. How did I get involved in this? So just by way of background, my main responsibility at Georgetown, in addition to the centers, is actually to direct the program on kidney physiology, to teach the students about kidney and electrolytes, which doesn't seem very integrative necessarily.
Really basic science program.
Totally
teaching,
basic
right?
science.
Yeah.
So the question of how did I get involved is an important one, because I think it's a reflection of, in some ways, how academic medicine has moved from where it is. So back in 1997, we began a series of lectures at Georgetown University to the public. It was a way of informing the public. We called it Mini Medical School. There were about 20 other medical schools in the country doing this. And the idea was, let's invite the public to come to our academic health center to learn about science, to learn about medicine. Many times people come to this institution when they're ill, critically ill, serious conditions, and it's a scary place. And this was a way to open up the door and say it's also a resource for the community. Well, we brought people in and invited folks to come and listen to lectures on science and medicine. And at the end of 8 lectures, 8 Tuesdays in a row, we asked the cohort of 200 people, what do you want to hear about next time? Do you want to hear about an 8-part series on neuroscience, on the brain, on cancer, on cardiovascular disease, the main issues? Mm-hmm. No. The number one topic that was requested was nutrition, as you mentioned. And the second topic was alternative medicine. And what did I do with that? I ignored it, because I knew better. And so the next semester we had 8 other lectures on science and medicine. And at the time it was the trial of O.J. Simpson, if you remember back when, and everyone was all excited about DNA analysis, so we gave a lecture on DNA, molecular biology, from who we are to who done it. It was a way to explain molecular biology. And 7 other lectures, and at the end we asked people again, what do you want to hear next time, next semester? And the same answers came, nutrition or alternative medicine. And it took me 3 semesters of people telling me, well, this is what we want to hear about, before it dawned on me that, you know what, we're not listening to the public. We're not listening. And so the 4th semester, we got smart. And I found 2 faculty members to put together a lecture series on topics related to, quote, alternative medicine. Some was on acupuncture, some was on herbs, some was on mind-body medicine. And the upshot of that was, it dawned on me that here we were telling the public things we weren't even telling our own students. And so that propelled me to read a bit about this field. And I read one of your papers, actually, Dr. Mm-hmm. Jonas, where you made the point that we're in a position where the communication gap between patient and practitioner was widening, and that we weren't listening to the public, and the public is looking for answers. And so that was a profound influence in my own thinking, and propelled me to put together a team to write a grant, mm-hmm. with the idea being not that we were going to train practitioners of complementary therapies or alternative therapies, but we were going to train medical professionals that would be aware of the advances in the field and be able to advise their patients in a more rigorous and informed way. So this was about patient-centered care going to another level. And so we began the process of integrating material into our courses. And initially it was a bit eyebrow-raising to have a lecture on the anatomy of acupuncture in a gross anatomy course. But gradually it became clear that what we were doing was really training our students and our faculty, I might point out, about what therapies are out there, what was the state of the evidence, and taking a fairly rigorous approach to inform our community. And that began to change the whole view of what does it mean to practice patient-centered care.
Right, so this was really a way to get at, a pathway to get at patient-centered care, because patients said, I'm using it, I want it, I need to know about it, I need my physician, my nurse, my healthcare practitioner to also know about it.
Exactly, and in many cases the patients were coming and saying, tell me what I should do.
Yeah.
It wasn't coming with an agenda necessarily saying I need my yoga instructor,
Right.
but I have back pain.
Right.
Is it chiropractic, or is it surgery, or is it acupuncture? What do I do? And even if a physician was very interested in helping the patient, if they didn't know what alternatives, what options the patient had, they weren't really doing their job very well. And so we viewed this as a responsibility to inform our community. What came out of that, of course, was a different view of how do you view your patient, and also a sense of humility on the part of the practitioner, the physician. You know, there are things that I actually won't be able to do for my patient. I'm going to have to build relationships with practitioners in the community. And that's also good for medicine.
Yeah. I want to get back in a little bit to the whole issue of what does the physician of the future need to know and how do we need to do that. But there are two aspects of what I'm hearing you say as to why you did this and how you did it that are near and dear to our hearts here at Samueli Institute. One is that you were anchoring it in good science, good evidence. That's how you determined what was the best to integrate. And second, you did something that I think was fairly unique of the programs in these areas, is that you reached out to the alternative and complementary practitioners, the acupuncturists, the massage therapists, the chiropractors, those folks, practitioners, professionals who are outside of the field, and said, let's work together. And set up some of the most integrative discussion, if there is a term like that, or some of the best dialogue between the professions, again, with the idea of let's do the best for the patient. I've been impressed by that. You want to talk a little bit about that?
So that's a very astute observation, that the path we chose was twofold. Number one, there was information that we wanted our students to know. Call that the cognitive element of the program, which is what knowledge, what facts, what information should the students have, and who should they get that information from? And so we made a conscious decision from the beginning that what we were going to do is bring in practitioners to talk about what they practice. For too long in this country, back in the 70s and 80s, there was quite a bit of contention between the different disciplines, between the medicine, academic medicine, and conventional medicine, and the chiropractors, for example, had to go to court to settle their disputes.
Right.
But in any case, the idea is that many of our students are going to need to know about these practitioners, develop relationships in their communities of practice, certainly in primary care, maybe even in the hospitals. And it was important for them to begin to know what each other does. And so rather than have one of our faculty from science or the clinical side talk about a discipline that they don't practice, we felt it was important to bring the practitioners in. I'll say initially there was a bit of defensiveness as individuals came to present their credentials and tell the class, well, we spent 4 years and we learned a lot of science. And very quickly I used to pull those folks aside ahead of time and say, you're coming to a group that accepts you as you are. You don't need to do that anymore.
Right.
What you need to do is dive right in. And the most important thing you can tell our students is, how do you decide what to do? And so one of the things that we've brought into our system, to our training system, is to have a panel, and to have a panel of practitioners. And then, for example, if we're dealing with a back pain patient presents with back pain, how would a chiropractor approach it? How would an acupuncturist approach it? How would a family physician approach it? And the students are also invited to ask them, how do you decide when the data's not there? How do you decide what to do? And so what you're also seeing is a philosophic approach that might differ between the practitioners, but what it does is it allows the students to begin to form their minds about how they will practice and how they will begin to develop relationships. So, in essence, what we're looking at is that there's no one pathway to health. There are multiple pathways to health, and patients will choose a path that's resonating not just with their symptoms, but also with their philosophy of life. That's something we need to be attuned to, because it's ultimately going to help in the healing.
It sounds nowadays like so much common sense, but back then it was quite controversial, wasn't it? Even the idea of patient-centered care was new, people weren't sure what it is, and we're still trying to figure it out, but it sounds like this is a pathway always into providing more patient-centered care.
Your point earlier about attitudes is a very important one. That was a very important outcome for us, is that we felt that by introducing integrative medicine, by bringing in elements that many of our faculty were not aware of, many of our students were aware of, practitioners that they hadn't seen before, it introduced an element of uncertainty. Like, wait a minute here, this is new. We haven't done this before. Is this really part of medicine? And yet, well, here's my course director bringing it in. And what I used to tell our students is, I want you to listen to people come in, but don't look at me for answers. You need to begin to formulate your own thinking about this. Right. And so this is really about what's the bigger picture here. And also move away from the notion that students have initially, which is they got to fix people. That if they don't fix the patient, then they failed. And healing is not about curing something. Healing is really about living, managing, creating a higher state, a quality of life. All these elements come into the healing process. And too often, as we focus on disease, something we may come to in a minute, then that's the goal, is to eradicate disease. But in fact, what we're talking about is health, a continuum from optimal to, very much less optimal, and everything in between. And that's a different concept for students.
Yeah. I think, you, as you know, here at Samueli Institute, our subline is exploring the science of healing and making healing as important as curing in our system. And I think that's a really important point, is that healing and curing are different and they intersect. And integrating them is what the true integration is about in these areas.
Well, we've been guided quite a bit by what you've done here at Samueli.
You mentioned something earlier when you started this up, that it wasn't just about educating the students, but it was about educating the faculty. And I know you've got a new endeavor now that is focused really on training faculty how to be good educators. If you don't mind, can we switch a little bit over to that? Because I want to ask you about the future of medical education. And what you've described is integrative practices as a pathway to a more holistic and patient-centered type of medical practice. Is that what you're also trying to do at your new center?
So the new center is related in concept, but addresses something even more fundamental. Here's the reality that occurs in virtually every medical school that I know of in the world. Individuals are hired and brought on board on the faculty to primarily do research or to primarily see patients. There are very few individuals that are primarily brought to teach. And so the reality is we have individuals that have content expertise, be it in science or be it in clinical practice, but they haven't been trained to be educators. It's one thing to give a single lecture and to share that expertise, or to have students with you on rounds as you see patients and they observe in an apprenticeship model how you care for patients and basically see what you do and try to mimic that. But when it comes to education, when it comes to developing courses, to designing curricula, to optimizing learning, teaching and learning settings, to determining assessment. How do you examine? What is it that you want to know? All these things require a much higher level of professionalization that most of our faculty don't have. And so at one end of the spectrum, the idea is that we would want to have a cohort, a subset of individuals, the ones that are most intimately involved in developing curricula and courses and our clinical experiences, to have additional training an additional skill set related to how to be a good educator. And so the tagline for our center is called Educating the Educators, which is we need to provide that kind of faculty development and professional training to help people become better at what they do in the classroom. And there are many, many aspects to it. I mean, for example, in this day and age, 2015, the notion that the only way to educate a group is to bring them into a lecture hall and to talk to them for 8 hours all day, it makes no sense. The fact is the students have all the information at their fingertips. What they really need to do is take that information and apply it in a case setting, in a discussion, to formulate their thinking. One of the most exciting things that we're doing is something called flipping the classroom, which is they don't come into the classroom to hear us. You know, it used to be when you were in grade school that you were in class all day and then you went home and you did problems, homework, then you came back to class and you discussed the homework. The idea today is to completely flip that, is that to go home and on your phone or on your iPad, you watch a short podcast, which would be a condensed version of the lecture, which would eliminate a lot of the redundancy and just give you a 20-minute short condensed version, something like the Khan Academy does on topics. And so you would watch that at home, and then you would come to class and actually do problems in class that are facilitated by instructors. And so the entire class setting changes from am I passively listening or am I actively engaging? That's catching on very quickly across most medical schools. Many law schools are taught like that now. And I see that changing in the thinking. And so the whole notion of education, if you haven't been exposed to it, or how do you design a class, how do you design a case, what sort of engagement do you do with the students? If you have a room of 200 students, it's impractical to call on people. On the other hand, with the use of what we call audience response systems, which are small remote like remote control objects that have A, B, C, D on them, students could quickly select their answers, or you can even do this on your cell phone, on your smartphone, and record answers to a question, and quickly get a spectrum on how did the class respond to a particular question. And if you're clever as an instructor, you put in choices that aren't so clear-cut, because you know what? Medicine is messy. It's not clear-cut. Sometimes it is, a lot of times it isn't. And so then what happens is the students have to debate their choices and argue. And so the whole notion of education changes in this new system.
So it sounds like this approach would allow for a number of other things that tend to be left out of medical education, but are important, especially if you want to integrate healing and curing, like we talked about before. I often say that to become a brain surgeon, you got to practice on a lot of other people. To become a healer, you got to practice on yourself. So does this offer opportunities, or do you integrate in this type of education small group exercises, experiential components, skills training? For example, patients often complain about doctors that they're not very good communicators. They don't listen, they interrupt, etc. Can that be trained in these kinds of settings?
So thank you for that question, because this is probably the most successful aspect of our broad initiative that we undertook at Georgetown, which was focusing on the experiential component. So as I said earlier, there were two elements to our curricular initiative. One was cognitive, which is what knowledge, facts, information students need to know. But a second, and actually much more important aspect, was the non-cognitive, which was the emotional and experiential component. And the idea behind that element was we were going to expose students by having them experience various techniques to foster self-awareness, which we hoped would lead to self-care. And the self-awareness component was really for a student to begin to think, how do I react to things? What makes me tick? How well do I know myself? And the techniques that we use to foster that are things like meditation, mindfulness meditation, concentrative meditation, different forms. We used guided imagery. We used writing exercises, narrative reflections. We used movement. And we combine it with music and with art, various approaches that are all designed to have the student begin to see how do they react to certain aspects as things come up for them, but not rationally think about it, emotionally experience it, and begin to know themselves better. We do this in groups of 10 with 2 faculty facilitators. And since we began this program in 2002, so 13 years ago, we've trained over 90 members of our faculty to lead these groups from across sectors, science and clinic and the library and many, many other sectors. But the idea is the students have 2 hours a week for an entire semester to be in these groups of 10 with 2 faculty. The faculty are participants, not just facilitators. And what goes on in these groups is really a discussion about how you're doing, what do you notice about yourself, and as you experience a technique, what impact did it have on you? Everybody's experience is slightly different, and we learn from each other. Now, in terms of becoming a communicator, what happens is you just imagine you're in a group with 12 people. One person is speaking. The ground rules are not only is there confidentiality, but you're coming to this without judgment. That is, this is the one time in your training where you're not judging, you're just listening. You're listening respectfully with an open heart, we call it, and you're just listening. You're not deciding, I agree, I disagree, I like, I dislike, it bothers me, it doesn't bother me. You're just listening without reacting, but observing. And what it does is it cultivates a skill of listening on the part of the students that they don't normally have a chance to do. That is, they're constantly, one of the knocks on physicians is by the time you're talking, within 20 seconds, they're already writing out a prescription or they're coming up with a treatment protocol. And here we have the students just listen to each other without doing anything except observing. And that power of observation, we believe, is translating into a better communicative skill, a better listening skill, a more empathic student. And that we have data on. We have data that practicing mindfulness meditation, reduces their stress level, which is a key to this. They become more empathic. They become less burnt out, which is a huge issue in the medical field. Studies suggest that 50%, 1 out of 2 physicians, is experiencing burnout at some point in their careers. It's important for us to help our students gain the skills to address that, to become more resilient. And we believe that these approaches between meditation and reflection primarily are key tools for them. And it's not just for our students. The fact is that the faculty that have participated in these programs found profound changes in their own identity as physicians and as teachers and as practitioners. My sense is that this will be a very important development that's going to move to many, many other schools. Right now, we have a training program for faculty to lead these groups. It's now in at least 10 medical schools in the United States and around the world, and not just medicine. There are nursing schools that have adopted it. There are CAM professional schools, complementary and alternative medicine, like a chiropractic school in Portland and an acupuncture school. Stanford University uses this approach to help their residents in anesthesia develop a resilience, a very tough profession that has had difficulty sometimes with resident well-being. And so my sense is that right now this is on the national agenda, how to foster resilience and how to improve empathy, foster empathy, and at the same time improve well-being in our health professions. And it begins with what we do educationally.
Yes, no. I think the burnout rate, latest data has shown that it's rising quite rapidly, especially among primary care physicians. So ways of addressing that is key. And I think every patient would love to have a physician that truly listens and empathizes with what's going on and doesn't just sit down and write a script immediately. But what I hear you saying is something even beyond that. It reminds me of Socrates' motto that to know thyself is wisdom. And are you trying to train healers that are also wise, and in addition to just being knowledgeable in these areas?
That's exactly the point. This is what we've evolved to. As we began to see the students adopt these techniques, we saw a change in their own perception of themselves. Our faculty that began to train to lead these groups noticed a change in themselves. And so Socrates was right. At the core is really beginning to understand yourself. And as you do that in a context that fosters that, you become a better practitioner, you become a better teacher, you become a better parent, you become a better spouse. There's quite a bit of data coming out in terms of what the impact is on an individual. And I say it again, in 2015, when we are bombarded with inputs, constant inputs to us, and what we don't have is time to disengage unless we forcibly do that. We need this more than ever. There's an interesting several studies that came out about a year and a half ago in the Annals of Family Medicine. One study looked at HIV patients and asked them, do you feel your care with your practitioner, that he's empathic or she's communicative and compassionate to you, and to rate the practitioners. And on the other side, they asked the practitioners, do you or don't you feel mindful? How do you consider yourself to be mindful? And the results were perhaps surprising, perhaps not. The more mindful a physician felt of themselves, the more satisfied the patients were about the care they were getting. And this is the exact flip side of burnout, where in burnout, the patients feel disengaged from a burnt-out physician, and the physician doesn't feel like he's giving adequate care. And so this is an intervention that actually can make a big difference. And so when those papers came out in the September 2013 issue of Annals of Family Medicine, Pauline Chen, who's a physician, wrote an editorial in the New York Times, "Is mindfulness the answer to burnout in physicians?" And her article was bombarded with people responding saying, this is what I needed when I was in medical school, or people in practice saying, this is what's saving me, keeping me in practice. And the ones that left said they couldn't manage it anymore. So we're on to something here. What we need to do is expand it further. I would say that now, again, in 2015, there's a recognition in academic medicine that resilience is a key issue for the workforce. This is physicians, this is nurses, this is social workers, this is everybody across the spectrum. That becoming resilient is really what we need to do to function as humans.
I know I got through medical school by doing Tai Chi every morning, and I had a Tai Chi master who taught me and was insistent that I get out there before I went into class every morning in the park and learn how to do that. And I'll have to say it really helped me a lot in terms of getting through. But I want to dig a little deeper here about the social impact and the social responsibility. We've talked about the didactic and the flipping and this type of approach, different approaches, the experiential and the skills building component, know yourself. But knowing yourself in the context of the social responsibility of providing health care and healing as well as cure can be very difficult approaching it the way you're talking about because you have to look at not only the positive things, this is more relaxing, I'm listening better, I'm calmer, but also the negative things. For example, once you start to know yourself, you know that you're full of unconscious biases, that in fact you treat people differently depending upon what you think of them, what their appearance is. And research has now shown that this contributes to health disparities, for example, and differential treatment of patients. How do you get at those issues? I mean, to uncover that in a student and uncover that in a practitioner and show them that they're not treating people appropriately because they don't know themselves well enough to manage that. Is this social component brought into the educational component?
It's becoming more and more recognized that this is an approach that has wider implications. I would say in the short answer is yes. There are a number of aspects of medicine, the dark side, if we will, the intensity, the biases, the disparities in care that we begin to uncover as we begin to look more holistically and broadly. These are all positive steps, I think, that are simply going to help us. There's also a sense that I want to point out at this point, which is there's a partnership here. You know, it used to be you got sick, you went to the doctor, you had the expectation that you were going to be helped. Well, this is a partnership in the sense that you as the patient have things, or I should say I as the patient, have things I have to do for myself. And so we enter into a partnership. What do? You know, and on my side as the patient, I need to think about my lifestyle. I need to think about how I manage my stress. I need to think about what am I doing Am I abusing alcohol? Am I being more responsible? What am I teaching my children? What am I feeding my children? What sort of, are we eating fast food, or are we going to learn how to cook and make better choices that are not necessarily more expensive? So in terms of optimizing health, which is really something I think you were alluding to when you talked about where the future is, when we look at the healthcare system and what we're training people to do, we are moving away from a disease management system to a health creation system. We're moving from the doctor, embodies all knowledge and all things, to a partnership between the practitioner and the patient. And I say practitioner because physician assistants and nurse practitioners are an important part of the primary care workforce, not simply physicians. We're also moving educationally from the setting of the hospital-based patient to the ambulatory setting, the clinic in the community, to the home. To giving instructions by email and over smartphones and answering questions that way. I happen to communicate with my primary care physician by email. And I'm a Kaiser patient. And through the Kaiser system, I send her an email when I have a question and I get an answer. And she takes the time to answer it, and we save quite a bit by not taking up clinic time for something that can be answered very quickly. So the whole notion of our healthcare system and what our respective roles are is slowly being clarified further.
So this isn't just about educating the practitioner of the future, it's also going to require educating the patient of the future to participate in this more collaborative approach. Person-centered means the person also needs to have more responsibility for their own self-care and their own inherent healing components.
Absolutely. If health is going to flourish, to use your term for this program, it's a partnership that's mutual.
Well, Dr. Haramati, thank you so much for coming in and being part of our podcast. Fascinating. We could talk many more, and I look forward to working in the future with you on these great efforts.
Thank you. It's been a lot of fun.
The concept of treating patients and not just the disease is one that we often explore here at Samueli Institute. There are so many modalities for physicians and healthcare practitioners to utilize: acupuncture, massage, chiropractic care, nutrition, that go beyond the traditional methods of care and focus on healing the whole person, not just treatment of disease. The healthcare practitioner and patient must be partners in this integration of both healing and curing modalities. I learned a lot of these practices early in my career as a doctor, and am pleased to see that these techniques have now become a part of the mainstream. But healing goes beyond modalities. If the physician and practitioner can take an extra step in the care of their patient, really listen to their needs, this goes a long way in the effectiveness of any treatment. When we look at our healthcare system today and how we are training our future medical professionals, what are we doing to move from a disease management system to one that creates health? For those healthcare centers that utilize integrative medicine and nurture a patient-practitioner partnership, that is, patient-centered care, the future of medicine is bright.